Good afternoon. I hope everyone's awake after lunch. So thank you, Dr. Abuzakuk, for hosting this. This is such a huge milestone for all of us, and we're very excited to have this meeting going on. So our next speaker is Professor Rand Arnaout. I'm sorry if I'm not pronouncing it properly, but her talk is on decision-making and prescribing biologics in asthma, when, how, and what. So a little bit about Professor Rand. She's a consultant allergy and immunology physician at the Department of Medicine, and she's a consultant allergy and immunology in the Department of Pediatrics at the King Faisal Specialist Hospital and Research Center. She's the Associate Professor of Immunology at Al Faisal University, KSA. She's a graduate from University of Jordan Medical School in 1989. She did her internship and started pediatric residency. She did her residency and her allergy fellowship at the Medical College of Virginia Hospitals between 1994 and 98, and joined Duke University Hospital in 98 for immunology and stem cell transplant training. She is a diplomat of the American Board of Pediatrics, as well as the American Board of Allergy and Immunology. At the beginning of 2003, Dr. Arnaout joined the King Faisal Specialist Hospital and Research Center as a consultant allergist and immunologist. For the last 5 years, she's been serving as the head of allergy and immunology at the Department of Medicine. In addition, she's a consultant immunologist at the pediatric department. Dr. Arnaout is also an associate professor of medicine and immunology at the Al Faisal University in Riyadh, Saudi Arabia. So please welcome Dr. Rand.
Assalamu alaikum. And I would like to thank the organizers for inviting me for the first Emirates. That's a privilege because this is the first meeting, and I'm coming here from Saudi. Luckily, my PCR was negative with all the pandemic. I think they're gonna, with the pandemic, they're gonna give us like cards, like the pizza card, where you buy, and then you get a free pizza. So you will get vaccination free at the end with the as a prize. So today we heard a lot about asthma, and I'm gonna try go through this very quickly, so that because many of the things it has been repeated from the previous speakers. As we all know, is that bronchial asthma is a disease that's affecting 358 million people around the world, with a chronic airway inflammation, mostly leading to reversible, to a certain extent, expiratory airflow with mucus secretion and hyperresponsiveness, presented with cough and shortness of breath. In the severe form of bronchial asthma, these symptoms are persistent despite adequate treatment with high-dose inhaled steroids and other controllers, and long-acting muscarinic antagonists and systemic steroids sometimes. Up to 10% of the adults and 2.5% of children have a severe asthma. This is a small percentage from the total, yet it consumes more than 90% of the resources that are allocated to asthma as a disease. So this is just from global data showing us that it's a global problem with a lot of burden and increase in the mortality and morbidity due to the severity of the asthma. So the criteria that the ERS and the ATS put to define severe asthma, and I'm talking about severe asthma in particular because the first question is, who is the one that should be eligible for biologic? So it is the severe asthmatic. So what are the criteria for a severe asthmatic? It's somebody who has a frequent severe exacerbation with more than 2 bursts of systemic steroids, each for more than 1-3 per year. Somebody who has an evidence of airflow limitation with FEV1 less than 80% of the predicted, somebody with serious exacerbations that needs at least 1 hospitalization and or intensive care admission in the previous year, and somebody whose asthma questionnaire is more than 1.5 or asthma control test less than 20 in the past 3 months. The impact of severe asthma is huge because it increases the risk of airflow limitation because of the frequent exacerbation and the need to maintain corticosteroids sometimes permanently, and because of the healthcare resource use due to emergency room and hospitalization, ICU admission, and because of the complication due to the disease itself or because of the side effects of the steroids in particular. And usually this all leads to a poor quality of life. And in these patients, an add-on treatment has been recommended, which may include biological therapy to reduce the burden of the disease. So the burden of the disease in these patients comes from this exacerbation and hospitalization, from the continuous use of steroids, from the impaired lung function, from the other type 2 comorbidities, and the impaired health-related quality of life. So these are the adverse effects that in patients who are treated continuously with corticosteroids or who have more than total of 10 days of corticosteroids in the past years that have higher risk of pneumonias, cardiovascular disease, metabolic disorders, weight gain, depression, cataracts, and impaired renal function, also leads to osteoporosis and sleep apnea. These are the side effects that we try to avoid by by using a steroid sparing agent instead of using steroids continuously or frequently. So the first step in deciding on a biologic is to ask your question, does this patient have really severe asthma? So you need to confirm the diagnosis and rule out all the other differential diagnoses. The second question will be, what type of severe asthma are we dealing with? So we need to phenotype this patient. So what are the characteristics of this patient and his disease? And then we need to endotype, looking at the underlying pathology that leading to his manifestation. So, and we do this through biomarkers. You can do it through biopsies in a certain, but nobody will do that. So we need to do the endotype and the biomarkers. And then the last question will be then, if we do all of this, which one to choose so we need specific therapy for a specific that patient in particular with this phenotype and this endotype. So severe asthma is only part of the difficult to treat asthma, and this is confused all the time. That's why a lot of emphasis has been put on identifying each of them. So the poor control in asthma usually comes from either poor compliance, incorrect techniques, or coexisting conditions, or including smoking, allergen exposure, or the presence of comorbidity. So the broader shape is the difficult to treat, and when all the above variables has been corrected and the disease is still uncontrolled, then this is truly a severe asthma, not a difficult to treat. So this is like a broader term, difficult to treat, and part of it severe asthma. And in the study that mentioned by Dr. Muhammad a little while earlier, that the patients with the stage 4 or 5 GINA are actually only 24% of all the asthmatics. Among those, 17% of them are difficult to treat due to many reasons. And among the total, only 3.7% are those with truly severe asthma. So these are the ones that mentioned by Dr. Marilyn earlier, that are different percentage of people who have asthma and who have a comorbidity that aggravate the symptoms and make it difficult to treat rather than severe, including allergic rhinitis, chronic rhinosinusitis, vocal cord dysfunction, GERD, and so forth. So these are manifest, and you have to pay attention to also some of the drugs that are used, and ask your patient, because many of the patients are on some medication that make them cough all the time and have as if they are truly severe asthmatics. So those who will need a biologic are lie in the step 5 of the GINA guidelines, and you have many options to choose from according to the endotype and the biomarkers. So the severe asthma research previously have identified different phenotypes according to the age and also the presence and absence of allergy, the coexisting condition, the severity of air limitation, and the frequency of exacerbation and the response to treatment. And this is eventually they classify them, and now we can put them in type 2 high or type 2 low, or type 2 and non-type 2. And this is not a clear demarcation between them. It's not like black and white. There is an overlap. In the type 2 high lies the allergic asthma, the eosinophilic asthma, the exercise-induced asthma. And then in the middle, there is a late onset, especially in females, which lies between the type 2 and non-type 2. And then the obesity and smoke-related, and the neutrophilic asthma and the granulocytic asthma lies in the type 2 high. And this is from childhood to adulthood, and this is the severity parameter. So this is phenotype. This is the different phenotypes of asthma. So now this is the clinical presentation. Under these, we need to look at these phenotype, what are the underlying pathophysiology. So the measuring the biomarker will identify the endotype, and usually we are depending currently on 3 major parameters, which is the IgE level in the serum. And if you cannot measure it, you can do the RAS, which is the specific IgE for different allergens, or do the skin prick testing. The other parameter is the peripheral eosinophil count, which correlates with the sputum eosinophil level, and also the fractionated exhaled nitrous oxide, or what we call commonly is the pheno. So these 3 biomarkers we can identify. They are all of them measured, directed toward the type 2 high. There is very limited markers so far with the type 2 low. Maybe in the future we will have more markers to identify the type 2 low, and choose the right also agents for it when they become available. So let's look at each one of the biomarkers and what does it indicate. The eosinophil count, the eosinophils are actually their maturation and differentiation is directed by the interleukin 5. Their trafficking to the airway is driven by, and actually to the tissues, is driven by IL-4 and IL-13. They are involved in the maintaining long-term inflammation in the airways and are associated with fixed airway obstruction. The IgE, on the other hand, is secreted by the plasma cells under the influence of IL-4 and IL-13, and associated usually with allergy. The pheno is an indicator of the IL-13 driven inflammation and the production of IL-4 and IL-13. It indicates of oral corticosteroid responsiveness and useful in assessing the asthma severity. No single biomarker can capture the whole picture of type 2 inflammation. So you need a combination of at least 2 of those in order to give you a full picture of what you are dealing with. So this is if you don't get the serum IgE level, you can do the RAS testing, or you can do the skin prick testing, and here it shows a lot of positivities in the skin compared to positive and negative controls. So the GINA guidelines now recognize that an elevated IgE and the blood eosinophils and the sputum eosinophils and the pheno are the biomarkers of type 2 inflammation. And they have that there is an overlap between those. And the blood eosinophil count is more than 150, pheno more than 20, sputum eosinophils more than 2%, which is, we rarely do. And asthma, clinical allergen driven, and the need of oral corticosteroids. You have to understand that it's very hard to get the number of eosinophil that is indicative of the eosinophil or the high eosinophil count that is make the patient eligible if the patient is on oral corticosteroids, because it's the best apoptotic agent for eosinophils. So this is taken off steroids. So once you look at these, the asthma can be type 2 high, type 2 low, and under this, the type 2 high, there is the eosinophilic, allergic, eosinophilic and allergic, and there is the mixed asthma, and then it comes on the non-type 2 is the Th17 neutrophilic asthma and the postgranulocytic asthma. So what is the value of each one of the asthma phenotypes, burden, and how they overlap? If you look at the eosinophil more than 150 and the allergic together, it's 17.6 of the total. If you look at the eosinophil alone, it will be 13.2%. If you look at the eosinophil more than 150 and the pheno more than 25 and allergic, the three together 24.8%. If you look at the eosinophil more than 150 and pheno more than 25, 16.8%. If you look at the pheno more than 25 and allergic 5.7, and the allergic only is 10.7. So all in all makes almost 90%. And then we have the non-type 2 asthma, which is the eosinophils less than 50, 150, pheno less than 25, and non-allergic. This is consists of 9.4% of the total asthmatics. If you look at the elevated eosinol and or pheno, these are like it tells you what the patient would usually, in this case, they might be good for anti-IL-5. The elevated IgE alone will be good for anti-IgE. Those with all the spectrum might be good for dupilumab. Actually, it might be good for all of it, but this is like showing that what is the spectrum that you might be dealing with. So type 2 low, neutrophils, IL-8, IL-17, IL-22, interferon gamma, and it's neutrophilic or postgranulocytic. And then the type 2 high, where have eosinophils, IL-4, IL-5, IL-13, mast cells, IL-4, 5, and 9. And we have the Th2 cells and innate lymphocytes type 2. So what are the characteristics of the type 2? They have high blood eosinophils, elevated tissue eosinophils. They have serum IgE high, elevated pheno, variable response to steroids, respond to targets of type 2 inflammation, and they usually have type 2 comorbidities, and the cytokines involve IL-4, 5, and 13. The 9 type 2, on the other hand, are airway neutrophils or postgranulocytic, very cellular inflammatory cells, poor response to steroids, obesity-associated, lack of response to all the targets of type 2 inflammation. So biologics, what biologics should we choose for which patient? These are actually the different biologics that are available now in the field, and you have heard about many of them a little while earlier. And looking at anti-IL-13, anti-IL-4, anti-IL-5, anti-IL-5 receptor, anti-alarmins, and then some of them are coming soon for the non-type 2 inflammation. So now these are showing us those approved for asthma, and they have another approval for something else. Let's start with anti-IL-4, IL-13, which is directed toward the alpha receptor shared between both cytokines. It is approved for asthma, it's approved for atopic dermatitis and associated chronic rhinosinusitis, because sometimes when you have so many options, the only thing that will make you choose one versus another after you phenotype is the presence of another comorbidity that probably will be helped by the agent that you will be using. So this is the approval currently for the dupilumab. And looking at the anti-IgE, the omalizumab, we have it is approved for asthma. Of course, this is the very first agent to be approved. Recently for nasal polyps, and in phase 2 for atopic dermatitis. For the mepolizumab, it's not approved for atopic dermatitis. It's approved for asthma and approved for also recently for nasal polyposis. Ruxolitinib is approved only for asthma and for nasal polyps also. Bendrelizimab, on the other hand, is approved at phase 2 in atopic dermatitis for asthma, for sure, and phase 3 for chronic rhinosinusitis. Maybe soon they will get the approval for that too. Now we go to the the newest agent, which is the anti-TSLP, which in phase 2 trials for atopic dermatitis, phase 3 for asthma, and actually it has been in the 31st of December has been approved for asthma by FDA with no biomarkers. to be addressed. And I will show you that in a little while. And it's approved also, same thing for chronic phase 3 for chronic rhinosinusitis with polyps. INTIL33, it's in phase 2 for asthma and for atopic dermatitis. So what about the approvals and what are the details approval of these things for asthma and the others? Omalizumab is the very first one. It is approved for severe persistent allergic asthma with frequent exacerbation, so it's stage 5, and it's for age more than 6 years. The dose ranges from 75 to 600 according to the weight and also to the IgE level, and with convincing evidence from the very old data from before. And for the Mepolizumab, which is the second one, anti-IL-5, it's for severe refractory eosinophilic asthma for more than age 6, which is the most recent. It's 100 sub-Q Q4, and it was approved by first the DREAM study, then it came the MISNA series, and it's for eosinophil more than 150 in the previous 2 months, or more than 300 in the past 12 months. We come to the Bendrelizimab, which is the anti-IL-5 receptor. It is for age 18 and above, for also stage 5 eosinophilic asthma. It's 30 subcutaneously for every 4 weeks for the first 3 doses, then Q8, which is this is a new advantage. It has been also mentioned a little bit by Dr. Mohammed by Sirocco and Kalima studies. And it's for the initial was for eosinophil more than 300, and then with the Zonda it was also approved also for eosinophils more than 150. For Dupilumab, for also stage 5, approval age is 12 years and above, 200. If it's only asthma, it's 200 milligram Q2 weeks with a loading dose of 400. If it's for other comorbidities, including atopic dermatitis or nasal polyps, it's 300 with a loading dose, the first loading dose 600. The Quest and the Venture were the initial studies that led to the approval of Dupilumab. So this is the GINA map on what to choose for which, but it is a little bit confusing, so I'll just make it simpler. So if you have a patient with type 2 asthma, and with comorbidities like atopic dermatitis and chronic rhinosinusitis, you will check the eosinophils and the FeNO and the IgE. If the patient fits this criteria, you will start him on Dupilumab 300 with a loading dose of 600. If the patient have type 2 asthma and oral corticosteroid dependent, daily dependency or bursts that lead to more than 30 days per year, also Dupilumab with the loading dose of 600. If the patient have type 2 asthma with no comorbidities and non-oral corticosteroid dependent, if it is allergic asthma with an IgE more than 30, you will go with the weight and also with the IgE level, and you follow their the instruction, and he can receive Omalizumab or Xolair. And the other option is also to use Dupilumab of 200. If the patient is mixed phenotype with more eosinophils more than 150, IgE more than 30, and FeNO more than 20, then this patient's actually the best option is to go with a Dupilumab 200 with a loading dose of 400. If the patient have eosinophils asthma with more eosinophils and he does not have an IgE level that is high, then you can use MIPO or Pendra, and if it fails, you can go ahead and use the Dupilumab. In December 2021, the anti-TSLP antibody Tezepelumab was approved by the American FDA for the add-on maintenance treatment of adults and pediatric age 12 of years and above who have severe asthma and with no phenotype or biomarker limitation when the approved label. Actually, when the anti-TSLP was initially, we were hoping that would really address these patients with the non-type 2, but actually, eventually the approval came with no phenotype. This is showing that we have a lot for the type 2, but we have very little for the non-type 2. And the issues now with the needs more further exploration is that after 4 to 6 weeks, if the patient doesn't respond to your biomarker, what are you going to do? Probably you will need to think again and hopefully can switch. There is very little data about switching, but there is a lot of like indirect evidence for switching from MIPO and OMA and to other biomarkers. Combining biologics is another same problem that we don't have so much data about. And in this case, it's the cost is an issue. So this is just my summary saying that 10% of the patient actually consume 90% of the resources. And in order to gain and maintain control of the asthma, 3 biomarkers are valid right now: IgE, blood eosinophils, and FeNO. They will direct you to which biologic to use for which patient after confirming that this is a patient with severe asthma and stage 4 GINA. Treatment biological agents, most of them are now targeting type 2, very little for type 1, type 2 low. And with this, I thank you so much for listening and enjoy the rest of the meeting.